the minimally invasive sinus floor elevation utilizing the Jeder system. The Jeder system was invented in Vienna, and I am an enthusiastic user since 6 years now. I am very interested in 3D template guided surgery and the prefabrication of prosthodontics too. And sometimes people ask me if it is really necessary to use these techniques in common treatment cases. Well, if you ask me, I would say yes, because the benefit for our patients is enormous. Let me just show you a typical case. In the region of the right upper molar, we only had a residual crestal bone height of 1 mm, and in the region of the second premolar 4 to 5 mm, which is, as far as the ITI treatment guide is concerned, a typical indication for a lateral window technique. When you take a look at the post-operative X-ray with the knowledge in mind that we had chosen a crestal approach, it is sometimes surprising for some people to achieve such an elevation without the necessity of a lateral window. What interests me most when I follow up with new surgical techniques is what are the main benefits for our patients. For example, less pain and a shorter period of time of inability to work. If you choose a classical approach for sinus floor elevations, the average length of inability to work is 5 working days. The decrease of the days of inability to work is enormous when you choose a minimally invasive crestal approach to an average of 1/5 of a day, which was investigated by Philipp Jesch in Vienna in 2013. This is an effect that I can confirm from my own experience. Did other authors come to similar results? Let us look at further scientific research. You will find evidence for the benefits of minimally invasive or flapless surgery in scientific databases like PubMed or Web of Science. Taking into account the time that we have today, I have chosen one paper by Fortin et al., which was published in 2006. The main aspects in this paper on the effect of flapless surgery on pain are the following. You will find a higher number of patients who felt no pain at all. The overall number of painkillers taken by patients is lower. The number of tablets taken decreased in the group of minimally invasive surgery patients much faster compared to a classical approach. When it comes to the question which minimally invasive sinus floor elevation technique should be preferred, you are really spoiled for choice. There are so many techniques we could talk about it for a week or two. I've tried most of these techniques and some of them are still in my repertoire. When you try to categorize them, you will find osteotome techniques, techniques utilizing special drills and burrs, piezo surgery techniques, etc. I find it so interesting that I am working on a systematic review at the moment, and I hope to finish it at the beginning of next year. Again, just as a matter of time, I will concentrate on my personal favorite technique, which allows to solve nearly every sinus floor elevation successfully. It is called the Jeder system, and I would like to provide some impressions of this technique for you. Enjoy! These are just some impressions of clinical aspects through my microscope. We will talk later about the details, but as you can see, it is possible to get access to the sinus floor flapless. Or with a classical approach with a flap design. The inventor of this technique is unfortunately not me. It is Dr. Klaus Eder from Vienna. Klaus is a lovely, nice guy, and I was able to have a look at the system and at this technique in Klaus' own dental practice in Vienna at the beginning of the decade for a week. Dr. Philipp Jesch is the co-developer and one of the heaviest users of our Jeder community. Klaus' daughter, Professor Dr. Michaela Bayerle-Eder, is the CEO and the coordinator of research activities of the Jeder company. And if you need help or if you have further questions, please get in contact to Rainer Bandorf, who is also the contact person for first surgery support for new users of the system. Let us now have a look at the hardware. The main component for me is the display with the pressure control unit. And the main principle is to perforate the cortical sinus floor without damaging the Schneiderian membrane. In most of the times we can maintain a water pressure of 1.2 to 1.5 bar in our pressure chamber, in which we insert the special Jeder drill. To maintain the pressure and to pump further amounts of sterile saline solution into the sinus, we use a motor-driven syringe, which you can see here. The whole system contains a pressure control device and a mechanical device for vibration to detach the Schneiderian membrane. The motor-driven syringe is controlled by a foot pedal. And last but not least, let us have a look at the handpiece and the Jeder guide with the pressure chamber. This is a part which has developed evolutionary over the years. The next step is a one-piece combination, which is the current object of research. Let us now have a look at the surgical approach and the protocol. On the photo on the left hand side you can see the so-called ATP punch, which stands for atraumatic tissue punch. The ATP punch was developed by Professor Jesch, Dr. Philipp Jesch's father. Here you can see an intraoperative aspect of the flapless approach. For those who prefer a classic approach, maybe in connection with any augmentative steps, for example bone augmentation or connective tissue grafts, or for those who prefer a better overview of the surgical site, it is also possible to have a classical approach with a flap. As you can see here, where I grafted a connective tissue additional to the sinus floor elevation. The first step is the pilot drilling. In this case with a 2 mm drill close to the sinus floor without penetrating it. Our aim is to get as close to the sinus floor as 1 to 2 mm. On this photograph you can see the Jeder guide with a clear silicon sealing element which maintains the tightness of the pressure chamber against the soft tissue or the osseous structures when performing a flap procedure. This is a picture of the Jeder drill before it is inserted into the pressure chamber. I've prepared a video sequence to demonstrate the whole procedure for you. I marked the surgical site with the ATP punch through a 3D surgical guide. I take my time to remove my tissue punches properly because I often use them after the augmentation, as a graft on the buccal side, or set them back after the augmentation. I use an adapter sleeve to reduce the drilling diameter to 2 mm. For the pilot drilling. which you can see now. Right now you can see another component which maintains the tightness of the pressure chamber. The Jeder system is really flexible. This is again the Jeder drill, and it takes a moment. Yeah, and now we start to pump saline solution into the pressure chamber. We wait until 1.2 bar is reached, and then I start drilling in a tapping mode. In the small picture you can see the pressure control device and the decrease of pressure when we opened the cortical sinus floor in an extension of maybe a pinpoint. Then you have to stop drilling immediately. I would like to repeat this final sequence once again. Wait until at least 1.2 bar is reached. Start drilling in a tapping mode and stop immediately when pressure decreases. Which is right now. That's it. The next step is the lifting of the membrane. I remove the drill, close the pressure chamber with my finger and start pumping again. I take my time to let the pressure and the oscillating water column detach the Schneiderian membrane till I reach my prior determined volume, which you can see in the video right now. Afterwards, I enlarge my tiny tin point perforation with a round diamond burr. Or for those who prefer piezo surgery, with a round tip. The membrane is still elevated at this moment. And then I pump back the saline solution out of the sinus. And you can see there are no air bubbles or anything like that in the hose. Augmentation is a topic which we could talk about for at least a weekend. In this case I grafted with a bovine bone substitute material, which is often a little bit time consuming through the small approach. So it is worth to take a look at proper alternatives, but we will get to this point in a minute. And finally, the implant placement. If it is possible to have a one-stage surgical protocol, place your implants right now. And here you can see a tridental implant and the tripod. Always looks very fancy. And here's the implant. Let us now take a second look at the augmentation alternatives. In the literature you can find evidence that if you can maintain the space, for example with an implant, a blood clot still itself can be enough for proper bone formation. What I often use as a bone substitute are APRF membranes when I can ensure that the implant is maintaining the necessary space. I learned this technique from Dr. Joseph Schockgrun in Nice, and I recommend his courses together with two great surgeons, Jérôme Sommelian and Alain Sion-Prairie, a lot. It had been a very inspiring weekend in southern France for me. By just drawing some venous blood and using an easy to learn protocol, you will be able to produce your own bone substitute material for one-stage surgical sinus floor elevation procedures. In the video right now you can see a so-called big membrane. And smaller typical APRF membranes, which I often use as a graft or two. Lovely technique. When it is necessary to perform a two-stage procedure, you can use PRFs to build a so-called sticky bone instead of using pure granules, which is a huge handling advance in my eyes. Let's have a look at the surgical tabletop. I'm sure anyone will agree that it is more comfortable to handle a putty sticky mixture than a handful of granules. For those who do not like to draw blood or who do not like to invest in a new technology, it is worth to consider the use of cross-linked hyaluronic acids in one-stage sinus floor elevation procedures. It is really easy to apply, it has an antibacterial effect, and it is quite cost-effective. And here you can see the easy handling. It's very fast, very safe. For those who like xenogenic collagenated cortical cancellous granules, I have made a video of another product which is very easy to handle in combination with minimally invasive sinus floor elevation. And you can use it with a syringe. It's very fast, it's very safe. And I personally made good experience with this bone augmentation substitute material. Let us now have a look at some clinical cases. The first case I would like to present to you is a healthy best ager who demands the best functionality and better hygiene conditions in comparison to a dental bridge which had to be removed. I suppose that everyone agrees that this situation could have been restorated conventionally, but he decided to go for a single tooth restoration with implants, so that I had to deal with a lack of bone, especially in the first molar region. This need for augmentation is typically solved by a lateral window technique normally. Due to the self-employment of this patient and his wish for minimally invasive surgery with the aim of a minimum loss of working hours, we decided to lift with the Jeder system from 1 to 12 mm in the molar region and from 4 to 12 mm in the premolar region. Here you can see the transverse slice of the CBCT in the region of the right upper molar before surgery. This is a clinical aspect of the right side, and as you can see, we had to deal with some minor other problems like loose fillings and crowns too, caries, and we did all of this simultaneously with the implant therapy. This is the post-operative panorex. At that time I often grafted with a bovine bone substitute material which is very radiopaque, so in my older X-ray pictures the graft is much better visible in comparison to PRF, hyaluronic acid or allografts. That is one reason why I like to show this picture, and the other reason is of course it was very successful. To be absolutely honest, I do not know any other technique to lift from 1 to 12, 13, 40 millimeters with such a fast learning curve and so much predictability for the patient as the Jeder system. This is a post-operative clinical aspect. I grafted an epithelial connective tissue punch to thicken the soft tissue and sutured a collagen fleece onto the donor side. The implant side of the premolar region was left for open granulation. This is the post-operative X-ray of the implantation which took place 9 months later. And the following X-ray shows the site after prosthodontic restoration. And as you can see, we changed our prosthodontic protocol to screw-retained restorations in comparison to the older restorations, which was an individual abutment and on top a cemented crown. I would have loved to graft another connective tissue for the buccal aspect from the canine to the molars, but my patient asked me for some patience because of his workload. And I'm still waiting for some years now. Keep fingers crossed for me because I love to graft. And last but not least, the occlusal aspect and the portrait 15 minutes after surgery. The second case shows another sinus floor elevation with a need of a huge amount of graft because of the lack of vertical bone. If we would have performed a lateral window technique, the septum would have been a structure of interest. When you perform a Jeder sinus floor elevation, it is really not a challenge at all. You will have a very steep flank, which is very useful, as you can see here. The graft is allogenic and mixed with IPRF, also known as sticky bone, and we will perform another vertical and horizontal guided bone regeneration on the crestal side with a plate from the Fast system. Again, the team around Dr. Shokun, but this is another topic. The third case is very similar to the second one, but I would like to give you an impression of the capability of the system. As you can see, this is typically not an indication for a crestal sinus floor elevation. But it is also possible to graft even large volumes if necessary. In this case, just like in the case before, we grafted allogenic bone plus PRF, again the so-called sticky bone. Case number 4 shows a simultaneous implantation and sinus floor elevation. This is the preoperative X-ray and this is the postoperative panorex. The following case is quite similar as the one before. You can see a lack of vertical, I was too fast. You can see a lack of vertical bone height in the cone beam computer tomography, and we solved it with a Jeder sinus floor elevation at 2 places at the same time. As you can see on the post-operative X-ray, and here the radiographic control after the prosthodontic restoration. But I'll get back to the post-operative X-ray. Okay. Finally, and because I love symmetry, I would like to present to you a similar case on the left side. This is a preoperative cone beam computer tomography with a nice septum between the first and the second molar region, and the post-operative X-ray. The graft in this case is again allogenic sticky bone, and the X-ray after prosthodontic restoration. If I could awake your interest for this technique, please visit our new YouTube channel Zahnaerzte Do24. I would really appreciate your subscription. We will post more and more topics, lectures, video blogs and live surgeries within the next months. Let me say thank you very much for joining us and taking the time. If you have any questions, please feel free to email me. Andreas at Zahnaerzte-Do24.de. Andreas at Zahnaerzte-Do24.de. Thank you.